Thank you very much, Natasha, and thank you for inviting us to share the results of our study, the Irish National Adverse Events Study. So, in terms of patient harm and patient safety, probably the seminal report on patient safety was the Air is Human, which was published by the Institute of Medicine in 1990. Suggested that up to 98,000 hospital deaths in America came from medical error. This was based on the Harvard Medical Study practice, which looked at 30,000 admissions to New York state hospitals. So what is an adverse event? It's an unintended injury which results in disability, discharge, prolonged hospitalization, or death. And the key thing is that it's felt to be caused by healthcare management. So if we look at the international data on adverse events, you can see that the figures do vary from as low as 4% in the USA study, the Utah and Colorado study, to the Australian study, which is as high as 19%. Significant amount of these adverse events were found to be preventable. And I have this my own personal story of patient safety. When I was working as a stroke physician in Aberdeen, this was one of my patients who was admitted to hospital following a stroke and needed to have a nasogastric tube inserted. So there was 2 patients on the ward who had nasogastric tubes inserted, and these were the check x-rays that were taken to ensure that the nasogastric tube was in the right position. You might note here that the nasogastric tube is in the wrong position. It's in the left main bronchus. Now, unfortunately, the doctors were distracted and the wrong x-ray was read, and the patient was signed off to start NG feeding. And this is the consequence of this. The patient suffered an aspiration pneumonia, was transferred to intensive care, but survived and recovered from this event. And one of the learning points for me was the reaction of the family. They wanted to report this incident in the hope that whatever in the system went wrong could be investigated and put right for future patients. So we did a pilot study in Aberdeen. This is Aberdeen Royal Infirmary, which serves a population of approximately 500,000 in the northeast of Scotland. It has all the major centres of maternity, acute medicine, surgery and paediatrics. And this study was often quoted as the Scottish Adverse Event Study, but unfortunately hasn't been replicated in a national study at the time. The adverse event rate was approximately 8%. 43% of these adverse events were preventable. 59% of them contributed to the hospital stay of the patient. Only 10% were reported by the hospital system. And the estimated annual cost to the Scottish health system at the time was nearly 300 million. I suppose the study was reported in different ways, and this was my own personal media response was that staying in hospital was as dangerous as bungee jumping as a result of this study. So now I'd like to pass over to Dr. Natasha Rafter, who led and was involved in doing all the work for the Irish National Adverse Events Study. Natasha, thank you.
Thanks, David. So the next thing to ask is, what have we got in terms of Irish data? So Irish adverse event information comes mainly from the National Incident Management System, which collects data on incident reporting. Now that uses a broader definition than what David illustrated there, for adverse events. It includes near misses. Reports go to the Clinical Indemnity Scheme at the State Claims Agency, and about 83,000 reports are reported annually, and this is across all HSE settings. I found it very difficult to find an actual rate being quoted, and in a 2012 report, I did find one which said that incidents occur in 2.9% of acute services contacts. However, we do know that voluntary reporting collects only a small proportion of adverse events, and studies that have compared this incident reporting with reviews of patient charts generally say that under 10% of adverse events found in the charts are actually reported via incident reporting. In Ireland, we also have serious reportable events that are reported to the HSE in the Clinical Indemnity Scheme. And this is a defined list of events, but no rate information is provided. So why do a national adverse event study? Well, for the reason that we have a lack of national data on adverse event occurrence. And this publication from the WHO, and I'm sure other patient safety publications, do advise to collect local data to provide the mandate for national patient safety action. And really, better knowledge for safer care is what we're all about. So the aim of the Irish National Adverse Events Study was to quantify the prevalence and nature of adverse events in Irish hospitals prior to the national clinical programs. So really a baseline adverse event rate in our healthcare sector. It was funded by the HRB as a demonstrator project for the Research Collaborative in Quality and Patient Safety. And we received ethical approval from the RCSI and RCPI Research Ethics Committees. And our hospital sites were also invited to table these approvals with their own research ethics committees. So the methodology was a two-stage retrospective patient chart review based on the Harvard Medical Practice Study methodology. Now, we adapted the Canadian Adverse Event Studies Operations Manual, web-based data collection tool and database. In stage 1, a nurse reviews the admission for the presence of at least one of 18 triggers, and in stage 2, the physician reviews triggered admissions for adverse events. To select our hospitals, we invited all 30 acute public hospitals in the Republic of Ireland to participate, and this excluded hospitals with a sole clinical specialty focus, so solely orthopaedic, maternity, paediatric hospitals were excluded. 18 agreed to participate, 6 declined and 6 did not respond. 8 were randomly selected, and these hospitals were stratified by HSE region so that we had one large and one small hospital in each region. All our hospitals remain anonymous. The study population is the index admission, which is the admission under review. Eligible admissions were those of adult inpatients in 2009 who had a hospital stay of at least 24 hours or who died within that time, and we excluded admissions with obstetric or psychiatric principal diagnoses. We used the local HYPE database at each hospital for the random selection of admissions, and we stratified into surgery and non-surgery groups based on the presence of anaesthetic codes which indicated that surgery was likely to have taken place. At each site, we oversampled to 300 to 400 admissions. We needed for our sample size at least 187 at each site, but we wanted to make sure that we generated enough in our random selection to account for ineligible or missing charts. Our reviewers were trained by researchers from the Canadian Adverse Events Studies, and to enhance consistency, all the reviewers were trained together over 2.5 days using 5 anonymised patient charts. And then after training, the reviewers independently reviewed 20 training charts, and these were compared between reviewers and assessed for inter-rater reliability. In a study where the judgments are made with regard to healthcare management, causation and preventability, it's very important that the reviewers are making these consistent judgments. And then in the field, to monitor our inter-rater reliability, 10% of our charts were deemed to be reliability charts, and these were double read by the reviewers in the field. And we assessed the measure of agreement using the Cohen's kappa statistic, where 0 is no better than chance, agreement no better than chance, and 1 would be perfect agreement. And in the field, our kappa values were 0.79 for the nurses and 0.59 for the physicians, and this compares favourably with other similar adverse event studies. In our stage 1 nurse review, we had 6 nurses. These were either local to the hospital site or they were research nurses, and all had at least 7 years clinical experience. The nurses were instructed to review the first 190 to 200 eligible admissions at each site, and we asked them to review 100 surgery and 100 non-surgery for the presence of any of our triggers, and the focus was on the index admission, and they were able to look for a period 12 months before the admission and 12 months after. This is our trigger tool, or list of the 18 triggers that our nurse reviewers searched for, like detectives in the chart. So these included adverse drug reactions, unplanned admissions within 12 months before or after the index admission, healthcare-associated infections, any dissatisfaction with care, etc. And this trigger tool is the same one used by the other adverse event studies. In our Stage 2 physician review, we had 3 physicians undertake the reviews, 2 retired respiratory physicians and myself. We had a surgeon collaborator to consult on the surgical cases as required. So surgeons reviewed the triggered admissions for adverse events. If an admission was reviewed by the nurses and not triggered, then it was deemed to not contain an adverse event. The physicians used a 6-point scale for the assessment of causation and preventability. And this is an example of the one for healthcare management causation. And as you can see, the scale runs from virtually no evidence of management causation. There is a middle zone where it's not likely or more than likely. It's still a bit of a 50-50 call. And then number 6 for virtually certain evidence of management causation. And when you look at a patient chart, you realise that nothing is black and white. And so a scale like this just sort of helps put some, I suppose, quantification on these judgment calls. And a score of at least 4 was required for the injury to be deemed to be due to healthcare management. In our analysis, we looked at the prevalence, which was the proportion of admissions associated with one or more adverse events, and the incidence density, the number of adverse events per 100 admissions. We weighted our results for the sampling frame, so that was the underlying ratio of surgery to non-surgery admissions in each hospital. Because of our stratification, we had 50%, but there'd be around 25 to 30 or 35% in the hospitals who underwent surgery, so we weighted back for that ratio. And this is just the flow chart of our sampling. So we generated a list of 2,600 admissions. We oversampled. In some hospital sites, we needed to use nearly 300, 400 of our randomly selected admissions to get our 200 eligible ones. It varied between sites. We didn't need to screen 746, so the nurses screened over 1,800 charts. Around 13% were excluded because they weren't eligible, and that was mainly because they had a hospital stay of under 24 hours. Around 1,600 were eligible for review. A few more were excluded for inadequate documentation, around 1.8%, and our nurses reviewed 1,580 charts. 55% were trigger negative and didn't go for further review, and 45% were reviewed by the physicians. So the physicians reviewed 703 charts. We wanted to compare with the national inpatients to see whether our ANAEUS study population was representative, and we were similar in terms of age and gender balance and mean length of stay. We had a greater proportion of our population that died during that admission, and that is probably because we excluded short stay admissions unless the person died during that admission. And as you can see, the underlying proportion of surgery patients was just under a quarter in the national sample, or in the national population. In terms of our results, we found adverse events in 211 out of 1,574 admissions, and 15% of these admissions had more than one adverse event. So we analysed 247 adverse events. Over 70% were judged by the physicians to be preventable. There was a clear increased risk with increasing age, and the mean age of admissions with adverse events was nearly 62 years compared to 55 years if the admission did not contain an adverse event. There was no difference in risk between males and females. The median length of stay was longer at admissions with adverse events, so 7 days compared to 4 days. And half of the adverse events were considered to be system-related. These are our main results in terms of prevalence. Our crude rate was 13% of admissions were associated with an adverse event, and with weighting this became 12.2%. Our weighted incidence density was 10 events per 100 admissions. In terms of the timing of the events, around the top line, O is occurrence of the event and D is detection. So half occurred and were detected during that index admission. But just over a quarter, that's in the second line, actually occurred before the index admission, but with a reason for the index admission. And just under a quarter occurred during the index admission, but weren't discovered until a subsequent admission. And I'll give you examples of these. So example 1's an infected cannula site, and that's delaying bypass surgery a week. And so that's satisfying the prolonged hospitalisation criteria for an adverse event. In the second example, atrial fibrillation is diagnosed in a previous admission, anticoagulation isn't prescribed, and the patient is readmitted in the index admission with an arterial embolism. In the third example, someone has a fall and is admitted overnight in the index admission. A fracture is not seen and they go home, and then they're readmitted after that. The fracture is diagnosed and they undergo surgery. We looked at the adverse event frequency by hospital site, and we found no statistically significant difference between our small and our large hospitals in terms of the prevalence, incidence, or the proportion that were preventable. When we looked by specialty, we did find a higher risk of adverse events in admissions where surgery was likely to have taken place, so 18% compared to 10%, and that was a statistically significant difference. This is an entirely a construct by the study about surgery, so this is not whether they were looked after by a surgical team or a medical team. And in fact, when we looked at the specialty code of the principal diagnosis, that difference diminished and was no longer statistically significant. And that is likely to be because quite a high proportion, maybe a quarter of surgical admissions do not undergo surgery. In terms of what is the outcome for patients of these adverse events, this was physical impairment at discharge. 2/3 at discharge had no or mild to moderate physical impairment with recovery within 6 months. Now, we didn't look at psychological impairment. 10% of the events resulted in permanent impairment, and 7% potentially contributed to death. And this distribution is similar with other studies in the field. The economic impact was significant. When we extrapolated up our 12% or 1 in 8 figure or risk of an admission being associated with an adverse event, we estimated that there would be 41,000 admissions in 2009 that were associated with adverse events. Each adverse event was estimated to result in a mean of 6.1 additional bed days, and when you use the cost of the bed day in 2009 of around €900, this was over €5,000 per event. This extrapolated up to an estimated annual cost of €194 million in 2009. Now, we know that this is an underestimate. We've only looked at adult inpatients. Most obstetric and psychiatric admissions were not included, and we only looked at additional bed days, so any sort of step-up care, additional surgery, extra clinic visits after the event are not included, and the societal costs, of course, are not included, nor the litigation, which I think in earlier talks was mentioned at around $300 million this year. So in conclusion, the Irish adverse event prevalence is within the international range, but at the upper end. A large proportion are preventable. It's a large burden on our healthcare system. And there is a need for an improvement in our reporting culture. So our result of 12.2% is significantly higher than that figure that I found of 2.9%. We've published the paper in BMJ Quality and Safety earlier in the year. We held pre-publication meetings with a number of stakeholders. Now, we didn't get as impressive media coverage as what Professor Williams got earlier. We were competing with an election and a gangland shooting. We've put in posters and presentations at a number of conferences, and we are having a dissemination event later on after this conference, which people are welcome to attend. We have an adverse event data collection tool from the study, which was funded by the HSE to be adapted from the Canadian adverse event study to our study. So it is a research tool now available to the HSE. And of course, a study like this is always a team effort, and we're extremely grateful to our nurse and physician reviewers in our hospital sites, which due to the anonymity we cannot name. There was a large team of led by Professor Williams, our co-PIs, a number of whom are in the room, including Dr. Condell at the back there has been running around, thank you. A lot of collaborators from Canada and RCSI, and we had a number of project managers. And thank you also to some key people with their support during the study and the setup of the study, and to the members of our advisory group. And I'll leave you with Florence Nightingale, who of course recognised this issue very early on. Thank you.